This is the third video for Unit 3.2 about specific needs for people with acquired disabilities regarding nutritional aspects. Obesity and body composition. In cases of acquired disability, there are certain biopsychosocial factors, such as those we can see in the figure: anxiety, depression, pain. These factors promote a sedentary lifestyle, weight gain, and obesity. Obesity will worsen the patient's situation. It exacerbates the psychological, physical, and behavioral difficulties of the individual, worsening the quality of life of the person and his environment, in addition to aggravating the situation of dependence. In addition, obesity can lead us to the cycle of diabetes and sarcopenic obesity. That is, the lack of physical exercise leads us to obesity, diabetes, and loss of muscle mass, which makes us practice even less exercise and continue within the cycle, a situation compromised in people with reduced mobility. Some of the benefits that the patient with obesity or overweight receives from an adequate nutritional guideline, together with an adaptation of physical activity, will be, in addition to the management of body weight, the reversion of diabetes and metabolic syndrome, improved mobility, improved cognition, improvement or prevention of depression, improved quality of sleep, decrease in the probability of neurodegenerative diseases, management of dyslipidemia, hypertension, and others associated to acquired disabilities, and prevent loss of muscle mass. Nutritional deficiencies and bowel transit. A nutritional deficiency occurs when the patient is not meeting the minimum requirements established for a nutrient or group of them. People with acquired disabilities may have nutritional deficiencies of one or more nutrients as a result of sequelae such as dysphagia if they eat less quantity or if they don't have access to certain foods. The most frequent causes of nutritional deficiency in people with acquired disabilities are inadequate intake due to selectivity or food restriction, impaired bowel function. This includes impaired intestinal motility, constipation, medication influence, refusal to feed, sensory alterations such as loss of taste and smell generating inappetence, interaction of some nutrients with drugs, food allergies, and finally, beware of associating weight with nutritional deficiencies as they are independent of each other. We can perform a biochemical analysis, detect and treat nutritional deficiencies, or prevent their appearance. The benefits of treating nutritional deficiencies by adapting the diet to the needs of the patient are prevention of associated nutritional pathologies, maintaining optimal health, increasing the variety of foods consumed, balance of body composition, keeping muscle mass and fat balanced, brain health care, delaying cognitive decline, intestinal health care, transit, and defecation. What can we say about sensory disturbances? They are common in people with acquired brain injury, and it is an underdiagnosed sequelae. In food, all the senses are integrated, with taste and smell participating to a greater extent. The alteration of any of these senses can occur with the absence of the sense, the decrease or the distortion of it. Losing taste or smell can have serious consequences on the individual's diet, since pleasure and appetite stimulation, and with this, the patient's motivation, as we can see in the image. The benefits of nutritional treatment in sensory alterations are the re-education of the senses. They can be recovered in a few cases, and if not, the rest of the senses can be trained. Appetite stimulation increases motivation for food, and food can be enjoyed by other senses, such as hearing when crunching a food. Meals are pleasurable. By increasing motivation and pleasure from eating, eating disorders, depression, and anxiety are prevented. Autonomy is encouraged, being able to differentiate foods in poor condition, for example. The total loss of the sense of smell, called anosmia, seems not to depend on the severity of the brain injury, but rather the location, being related to brain injury of the frontal and prefrontal lobe. We can see in different studies how anosmia can lead the patient to a negative change in eating habits, depression, anxiety, and weight loss, promoted by dissatisfaction and demotivation. Although smell cannot be recovered in most cases, some authors suggest tips for counteracting the effects of anosmia, such as air rooms frequently, put smoke detectors, do not neglect the kitchen while cooking, monitor body weight, ensure food safety by pointing out the expiration dates of products, avoid over-seasoning meals, enhance the color and texture of food to stimulate appetite by other ways. The same goes for taste. The absence of it is called ageusia, and it's usually accompanied by anosmia, thus having the same effects on health at the metabolic and psychological level. The system of taste and smell are closely related. Having seen this unit, we can conclude that knowing the specific nutritional needs of the patients allow the next points. Prevent or control the appearance of frequent pathologies in people with acquired disabilities, and improve long-term results and slow down the evolution of the pathology. Along with the adaptation of physical activity, avoid and attenuate imbalances in body composition, such as the loss of muscle mass or the gain of fat mass, dehydration or bone density. Maintain a stable nutritional state without having nutritional deficiencies or gastrointestinal problems that may aggravate or alter the quality of life of people with acquired disabilities. Avoid the appearance of eating disorders, food rejection, food-related trauma, compulsiveness, depression, or any other psychological aspect related to eating. Taking care of the nutritional health of our patients and families can have a positive effect on a social and personal level, and this includes adapt food and physical activity, adapt the patient's environment to their individual needs, and promote healthy lifestyles. With this, we will be able to promote autonomy and personal relationships and improve the expectations of rehabilitation and quality of life of the patient. Thanks for the attention.